Muchas gracias. Thank you so much for inviting me to speak about low risk non muscle invasive bladder cancer. My name is Angie Smith. I am the AUA Assistant Secretary for Latin America. I'm also Director of Urologic Oncology at the University of North Carolina. And in the next 10 or so minutes, I'd like to discuss three general considerations for deintensifying the management of low risk non invasive bladder cancer. And I'll just explain that a little bit about the fact that when I say low risk, I really mean low grade. And I also will include a little bit of intermediate risk as well because I think deintensification is probably relevant to that patient population too. I think the best way to organize these potential changes we could consider is through surveillance changes. So, thinking about the frequency of cystoscopy, the need for future cystoscopy. The second is biomarkers, using that as an adjunct to cystoscopy or even to decrease the need for cystoscopy. And then finally, the third is treatment. When we may be able to survey small, known low-grade lesions and some novel agents that you might be interested in hearing about as an alternative option to TURBT. But before we get into the bulk of the talk, I want to recognize that some who are listening might be, you might not always be treating bladder cancer. So I want to take a quick minute to review the difference between low risk and low grade and recognize that today I'm going to be talking a little bit about both. So even though the title is technically deintensification of low risk, I'm also going to be talking about deintensification of low grade disease as well. And some of those are going to be intermediate risk. So these are I like to come back to the AUA risk stratification table because it's helpful to understand what I'm talking about here. We have low risk, and that's the low grade solitary small lesion. All right. And certainly I'm talking about these patients, but I'm also going to talk about intermediate risk. And this is what I mean by that. Any of the low grade TAs that keep coming back. And I know if you treat bladder cancer, you've certainly seen it just as much as I have. Also, large low-grade TAs and multifocal low-grade TA bladder cancers. And these risk groups really do matter because we know that in a large retrospective series of over 1,400 patients with low-grade disease, they were stratified into low risk and high risk. And if you take it all together, you can see that intermediate risk compared to low risk, there were higher recurrence rates, higher progression rates, a higher cancer-specific mortality. However, much lower than you would see for high-risk disease. It tells us that yes, there's low rates of progression, 5-year progression-free survival is 95%, but they do come back, and it's going to be something that the patient's going to have to live with and consider over the course of their lifetime often. So with this backdrop in mind, let's start with surveillance and what we know. I will say, and I'm going to sort of talk a little bit about how the guidelines, how they view what we do for surveillance. So this is just a table that I put together, and I basically review the guidelines in order. So we have the American Urological Association guidelines on the left, the EAU in the middle, and the NICE guidelines on the right. I order them from most aggressive to least aggressive. And I'm not saying one is right or wrong. It's just these are the guidelines that we have to consider when we're looking at this. And if you look, the AUA guidelines, it's pretty, it's not that different for the low risk. Everyone seems to agree. We get a cysto at 3 months. We get a cysto about 9 or so months later. The difference here is that AUA and EAU do annual cystos, but NICE guidelines say you don't even need to do another cysto ever again. Maybe that's the right call, maybe not, but we don't have a lot of good evidence to suggest. What I do see a lot of differences are in intermediate risk. So these are low-grade recurrent. While everyone agrees, yes, we do we do at 3 months, this is where things differ. So AUA is, every 3 to 6 months for a couple years and every 6 to 12 months for 2 more years, and then annual cysto, where EAU is very broad. There's really not a lot of guidance other than you can do something in between low and high risk, and it's individualized. If you look at the NICE guidelines, again, they're most conservative. You do it one at 3 months, at 9 months, 18 months, and just once a year. You go very quickly to the once a year surveillance. But we have to remember that these recommendations are largely based on expert opinion. In fact, surveillance trials are exceptionally difficult to carry out because they require extremely large samples of really good long-term follow-up, particularly so for a disease like low-grade bladder cancer, which has very few events of progression. So what's the case against cystoscopy? Are we doing too much? Are we doing not enough? Well, I would argue it's not. It's probably on the end of too much. And I have a colleague of mine, Florian Schreck from Dartmouth, who did a very nice study looking at patients in our military system from 2005 to 2011. Basically, they looked at just the guidelines for cystoscopy among low risk at a time preceding even loosening some of these guidelines. And what they found was that cysto was overused in approximately 75% of patients, majority of them, with an excess of 1,800 more cystoscopies performed than recommended, which is interesting. But what does this translate to? Well, it translates to cost. Matt Mosinen is a urologist who works at the Brigham, performed a Markov model looking at the cumulative cost for a 5-year period and found it to be $52,000 for low risk, but $146,000 for intermediate risk disease, those who are low grade but recurrent. And so this creates not just financial burden, but patient burden. I thought this was an interesting study because, one would think, well, maybe these patients would like to do less. But this study, they did a hypothetical study. They asked patients in the UK whether they would accept a hypothetical biomarker compared to cystoscopy. And they found that about 90% of patients prefer cystoscopy if the test sensitivity for that biomarker is less than 90%. And 75% would accept a urine test if it could detect over 95% recurrences. Whoa, like that is a very high bar to be set. So we know we have, a high bar to be crossed before we can move from cystoscopy to biomarker-driven type of surveillance. But of course, there's also the urologist burden in terms of the number of cystoscopies that need to be done. And I think there's also the question of cystoscopy as a suboptimal tool itself. It's beyond the scope of this 10-minute talk, but you can consider that when we think about adjuncts like blue light cystoscopy, narrowband imaging that can improve detection. All right, so I think that, we talked about surveillance. I think the argument for overuse of cystoscopy leads naturally to biomarkers, which can both improve cystoscopy as well as avoid cystoscopy. And I'd argue that the use of biomarkers for deintensification is probably most applicable to intermediate risk low-grade disease, where we're surveying much more frequently than the annual cystos we do for low-risk disease, so the initial low-grade disease. Going back to the guidelines, both the EAU and AUA guidelines do not feel that biomarkers are sufficient to supplant cystoscopy yet. You can see that in the EAU, none of the markers have been accepted for diagnosis or follow-up. And again, the AUA say it's not routinely used as a urinary biomarker. And there's been more progress through the use of epigenetics, which has been used to create biomarkers with 3 main types. There's aberrant DNA methylation, there's histone modification, and non-coding RNAs. And the reason this is so useful is because epigenetic changes are common in non-muscle invasive bladder cancer, both for tissue and urine. And there's new markers that are basically being made use of, and I'll describe a few in this talk that are currently in use. Bladder, Xpert, Bladder Cancer Monitor, EpiCheck, although there are certainly others in development. The first is Bladder Monitor, and it uses expression of 5 genes in voided urine, plus it adds clinical factors to determine a risk score for the patient. This was prospectively studied in 763 patients undergoing routine surveillance for recurrent bladder cancer. And so, interestingly, I think during the pandemic, actually, we've been using a little bit more because these patients didn't want to come in for cystoscopy. You can actually have their urine sent off for this type of marker. Now, a positive marker doesn't mean the presence of cancer, but you might be able to use it to avoid cystoscopy because the negative predictive value is 97%. So it was designed as a rule-out test. Another is Xpert Bladder Cancer Monitor. This measures the expression of 5 mRNA tumor markers in a voided urine sample, and it provides an actionable negative or positive test using a 90-minute assay. And so there's been many studies underway to test its use in the surveillance setting. Sensitivity was 73% overall and specificity 81%. Among those who have a negative test, the probability of being disease-free is 94%. And then another urine-based hypermethylation biomarker is bladder EpiCheck. Again, testing for the surveillance of non-muscle invasive bladder cancer. And what it is a real-time PCR test that uses 15 proprietary DNA methylation markers to find bladder cancer. And it essentially gives a number between 0 and 100. It's calculated through a software algorithm. And essentially a score over 60 is considered positive. It's been shown to have a negative predictive value of 99% and 95% for non-low-grade TA recurrence. And the important thing here is it's not as susceptible to or influenced by infections or previous intravesical instillation therapies. So these are the different types of biomarkers that might be something on the horizon we might be considering. But again, that bar that must be met is actually quite high, and so I wouldn't say that any of these are being used routinely, and certainly I don't use them routinely in my practice. So now that we've covered biomarkers, I'm going to end with strategies to de-intensify management when low-grade disease is either known or newly detected. And going back again, the final time to the guidelines, both the EAU and AUA guidelines discuss appropriateness of fulguration as an alternative to resection under anesthesia. But they also acknowledge that we don't have very much evidence to guide us. And so neither discuss surveillance without fulguration or treatment, but it's certainly something to consider. I think that studies that evaluate active surveillance are notoriously difficult to accrue because of multiple factors. We were actually part of a study out of Vanderbilt that closed early because of slow accrual. These are patients with low-grade disease who we just surveyed. But we do have a number of retrospective series that demonstrate safety in this, and we have this systematic review that synthesized many of the studies with the conclusion that watchful waiting or active surveillance of these small low-grade tumors are safe. Only one study reported progression to muscle-invasive bladder cancer. And yes, there was a reclassification rate, but that was quite low and didn't have a significant downstream impact. The IBCG, International Bladder Cancer Group, also published their recommendations, and they note that for these low-grade appearing recurrences with known low-grade TA tumors, they can be managed conservatively with either office cysto, fulguration, or even active surveillance. So it is a consideration, and I certainly do that for some of my patients. But another thing coming down the line is an agent called UGN-102. This is actually a reversible hydrogel that contains mitomycin C. Essentially, at low temperatures, it's liquid, and so you keep it in the freezer until you're ready for it. Combine it with mitomycin C, and as soon as you put it into the body and it hits body temperature, it turns into a gel, so it can actually ablate tumors. And we know from the Olympus trial, the upper tract urothelial cancer trial, that it is very effective for low-grade recurrent upper tract urothelial. And so now they're studying it and testing it in the lower tract for bladder. And this was the OPTIMA 2 design. We were a trial site here. This is the phase 2 clinical trial. I'll talk in a moment on the phase 3 now, but this was phase 2 clinical trial, and we do have results for that. It was a single-arm study testing UGN-102, which is this gel with mitomycin for its efficacy. And the primary endpoint with complete response at 3 months, that was 65%. But more importantly, the estimated durability of response at 12 months of those who did respond initially at that 3 months was 60%, which is quite good. And most of the adverse events were lower urinary tract symptoms. And so I think this is really exciting data. And from that, the ATLAS trial is now recruiting. We actually have it open here at University of North Carolina. And these patients are randomized to either TURBT for low-grade TA recurrent disease or UGN-102, this gel. And then we're looking at complete response and disease-free survival from there.
So we're about at 15 minutes, so I will just end here by saying that we should be considering de-intensifying low-grade, specifically low-grade recurrent non-invasive disease. And there are a lot of strategies to do it. We can reduce cysto surveillance. We can replace or alternate cysto with biomarkers. We can choose to survey small low-grade tumors or consider non-surgical management of recurrences in known low-grade disease. So again, I look forward to any questions you might have in discussion. Muchísimas gracias.